please welcome Sandra Hernández.
I wanted to start with sort of two contextual pieces about behavioral health, because I think everybody in this room who works on integration, whether it's from the primary care side and physical health side or from the mental health side, certainly are aware of both the incredible opportunities that ACA brings, but also that this is really an incredible opportunity to think differently about families and family structures and how we support families, and also how we think about institutions that are in our communities and what roles they might play as we think about the opportunities of ACA, and really for the first time, at least in a generation of those of us who are in any form of clinical care, have to reintegrate the mind with the body. And I sort of want to start with, very personal sharing maybe, which is that I have an aunt who's in her 90s now. Actually, we celebrated 91 years about a year ago or so. And she has been caring for our cousin, who is a schizophrenic, who's in his early 60s, really for virtually his entire adult life. And at her 90th birthday, I got surrounded by my first cousins and said, what are we going to do? You know, Aunt is 91 years old, and our cousin really has not ever been integrated in any way, shape, or form into either a behavioral health system or, frankly, even into a physical health system. Doesn't have a primary care physician. We've had a lot of sort of family financial support to maintain him in a deinstitutionalized setting. But really, faced with that question, everybody came and looked at me and said, what are we going to do? Right? And it actually is a very complex question, right? Because it's not just a clinical question. It's not just what medications should he be on, could he be on, but it really is, as a family structure, how do you think about our roles and responsibilities with regard to him once my aunt is gone? And so it was an interesting conversation about how to plug him into a system of care, and also how to maintain a family structure around him. And I think in many ways that is an ongoing challenge as we think about system reform for better caring for individuals like him. I'll also tell you that we of course continue to have an extraordinary challenge with the stigma associated with behavioral health. And one of my daughter's childhood friends, when she turned around 11 or 12, really did get quite clinically depressed. It was very obvious. And I found it fascinating that her behaviors were becoming very typical of an acute teenage depression. And my daughter, very curious, very supportive, very loving child, quite empathetic, would come home and sort of say, are these things that she is doing every day things that she can change? It was really a fascinating conversation that we had. And but one of the other things that started happening, of course, was that all of her friends started pulling away, right? And leaving my daughter in a situation where she sort of said, I sort of feel like when she needs everybody more, everybody's sort of moving away because these behaviors are so off-putting. And then we started getting interesting phone calls from parents who would say, and these are in some cases clinical folks, physicians and the like, who said, you should be aware that these behaviors are happening with this young person and your daughter is spending a lot of time with her. And I sort of said, yeah, we've sort of been encouraging her to do that. Right, that is actually part of what you need to teach people about society and how you manifest a sense of community around them. And so whether you think about young people and schools and thinking about the tools that we can offer to young people to support their friends when they get into clinical situations like that and social situations like that, to really thinking about the systems of care for family support as we move forward in a more concerted effort, as you've been talking about over the last day, about how we go about integrating physical health with mental health. I think it's important to contextualize what we're talking about from a human point of view, but also from a healthcare financing point of view. The numbers are really quite stark about what the extraordinary opportunities are to both provide better care in better systems and think about the impact of not doing that and continuing to not do that as a U.S. system of care. Estimates of around $300 billion per year. You'd rather have that? No, this is fine. I'm happy to hold it. Yeah, thank you. $300 billion a year in the U.S. of the cost of doing things the way we have been doing them. $300 billion. And so the opportunity costs are really quite staggering of really what has been a long-term policy of taking care of mental health in one place and physical health in another, and developing very fragmented systems really by policy. And so what we have an opportunity, I think, to do now under ACA is to take advantage of two things. One is that, for better or for worse, as hospitals think about better utilization of their beds and reduction of their beds and getting people out of hospitals, for better or for worse, in California, we already got people out of hospitals, right, in the behavioral health side. So we don't actually have an over-bed problem. In fact, some people would argue we are under-resourced in acute care psychiatric beds. But I sort of think about it in the sense of much as we did with HIV care some 25 years ago, which was that nobody really wanted to be in an acute care hospital. And so what we did is we built systems of care that were community-based systems of care and really de-emphasized the utilization of acute care beds. And so while there are certain regions and pockets across the state where we are underbedded, I think the opportunity that we have is not to build people back into acute care beds or even chronic care beds. When I was director of health in San Francisco, we passed a bond to bring our seriously mentally ill residents back from state hospitals into the county. And we brought back 85 of our residents that we'd been paying for out of county. And they were all on well-controlled psychiatric medications, and their physical health conditions were completely, absolutely unaddressed. In fact, their medical conditions were more acute than our acute care hospital was for our skilled nursing facility for mental health. And that was really when it became clear to me that and we've, by the way, serial department heads, myself, Mitch Katz, now Barbara Garcia, have all reprogrammed the use of the skilled nursing facility to really have it do a lot more day care and day treatment and really try to reintegrate people back into the community. So the fact that we are not really overbedded does give us an opportunity to think about integration that is more community-based. And it does require that we think quite differently about our workforce, and that we think about it differently from both sides of our delivery system, if you will. On the primary care side, as we stretch primary care physicians like myself into doing a lot more specialty care before we send people out, to really bring into our multidisciplinary teams social workers, clinical psychologists, psychiatrists, and the like. I tell the story that if you take a week course as a primary care physician in advances in primary care, if you take a course for 5 days of, whatever it is, 50 units of CME, you get one course on Friday before whatever the last thing of the day is on what the best choice of antidepressants are for your patient population, in spite of the fact that in my clinic alone at San Francisco General, 75% of my patients are on an antidepressant. Now, we do have clinical support in the HIV clinic, but my main point here is that all of us on both sides will have to stretch to think about how we deliver a much more integrated delivery of evidence-based care as we take on these opportunities for integration. I also want to note that in conversations with hospital executives and also with payers, there is this incredible conversation that's going on today about what do we do with individuals who are very high utilizers of our system and of our medical care system, who have behavioral health issues, and where in many cases we have said we're going to handle behavioral health over here as a referral and really not exchange the clinical information across health information exchanges that we need to do. And a big part of that is us, I think, understanding what the opportunities are and what is actually allowable around information exchange between the two systems. In many, many situations, we have sort of put our head down and said, we can't share information that we do over here with this system over there. And in fact, if you look at what the rules and opportunities are, that's a myth that we need to unravel, and we really need to think about the sharing of information as everybody goes towards a lifetime clinical record. And our challenge in integration is not just in workforce, it's also in the exchange of information. And so the hospital executives in beginning to think about their integration as they move outside of hospitals, they are encouraging their departments to start to think about what can we do outside of hospitals, as hospitals are in their so-called second wave and really trying to get out of heads in beds and thinking about how we achieve the triple aim from an acute care point of view. And so they are extraordinary partners for us in communities as well. And it is, I think, incumbent upon us to begin to, as they think both about community benefits, but more importantly, as they think about delivery system reform, the behavioral health integration is at the top of everybody's mind, largely because the data is so compelling. If you take the other side of it, I think it's worth noting as well that the chronic conditions that the seriously mentally ill have are some of the most expensive chronic care conditions that we are facing today as from a financing point of view. And so whether it's neurologic disorders, whether it's obesity, whether it's coronary artery disease, whether it's very high-risk behaviors of smoking and the like, we're going to have to think about the chronic disease management system as well as our behavioral health system in addressing this population effectively. California Healthcare Foundation has done a tremendous amount of work well before I came, Catherine and her team and others, to document across the state some of the workforce gaps that exist today in California. That data is quite compelling. I would encourage you to go to the website and look at the almanac and think about how we, in fact, do expand our workforce in behavioral health to include our promotores, to include our community health workers, to include a large peer-based delivery system for mental health. And even at that, we have wildly underinvested in all of the clinical spectrum for behavioral health. That's a policy issue that the state of California, I think, will really need to address in a go-forward basis if we're going to get a handle on both the quality of life, the family issues, and the incredible opportunities we have at improving outcomes for all of Californians. The prevalence of mental illness is, of course, quite high. And I think the opportunity, therefore, for us to begin to think about this workforce a much more aggressive way and create much more incentives for us to expand our behavioral health capabilities across the state. So with that, I'll just say that we at California Healthcare Foundation are undertaking some planning, and the planning is really focused very much on how the tools and capabilities that we have as a foundation can be better utilized and can be directed at integration of physical health with behavioral health on a go-forward basis. And so over the next several months, we'll be coming back and describing really how best to go about doing that. We have many, many places in the state where innovations have worked quite well, where our primary care clinics have done an extraordinary job of integrating behavioral health. We'd like to be able to shine lights on those projects and those efforts that are working, try to expand those and try to support those, and to make sure that the payment of dollars follows those extraordinary delivery systems. And so we'll be looking at innovations, looking at supporting new innovations, and doing a fair amount of work also in sort of thinking about how telehealth can help us deliver some of this work going forward. We have an innovations fund at California Healthcare Foundation, and we're looking at companies in particular that are focused on populations in the public sector and that have tools and capabilities that might help us expand the reach of behavioral health in remote and other areas where there are vast gaps in behavioral health capabilities. So I applaud Karen and Sandra and everybody who's been working so diligently over the last period of time with ACA. There's a tremendous amount more work to do, and California Healthcare Foundation is very excited to be your partner. And so with that, I wish you all well. Thank you.
One of the problems that I keep being frustrated with is what I call the obscene underfunding of primary care, and everybody asking the primary care system to become medical homes and to be all things to all people, and the expectations are increasing. It's already underfunded, and the expectations are increasing faster than additional funding. How do we deal with that, really the true elephant in the living room?
I don't think, anybody in this room is surprised to know that our Medi-Cal rates are one of the lowest, if not the lowest, in the country. And that certainly is an extraordinary challenge for California. I do also think, though, that one of the transformations that we are early in and in the midst of as we moved into healthcare reform in California is that Medi-Cal now is a mainstream program. And as it becomes more and more of a mainstream program, it seems to me that the groundswell of folks who will be with a Medi-Cal card and looking for a primary care home and to get a variety of both pent-up needs met and ongoing needs met, that as a health program, financing-wise, will have a much broader base of stakeholders and constituents. And frankly, that's probably something we're going to need if we're going to address the question of access. It will mean nothing to have a Medi-Cal card if you cannot get access from capacity point of view or because of people being unwilling to take Medi-Cal. So I do think it's a huge question and issue. I'll tell you that I'm on the UCSF faculty. There was our annual Senate and faculty survey and meeting was a couple of days ago. And this issue, whether you're in an academic medical center, whether you're in a freestanding, clinic or office across the state, and we have many, many safety net providers who are standalone providers who are not integrated and linked anywhere. All of the provider community in all of these sectors are concerned about that issue. And I don't think it's an elephant in the room. I think it's a major policy issue facing California. And I think as Medi-Cal becomes a more prominent mainstream, if you will, payer source, it is something that we are absolutely going to have to address. I don't think there's any question about it. I think we're also very fortunate to have a wide and vast FQHC delivery system. Carmela's in the room. I know there's been a lot of conversations about thinking about how that payment stream also changes as we go forward. But there is no question that primary care physicians and systems are being asked to do more with resources that are not growing and that really are inadequate today to do everything we're asking them to do.
Let's give